Hello friends, I'm Dr. Sachin Kulkarni. I'm practicing as IVF consultant at Pristine Women's Hospital, Kolhapur, Maharashtra. Today, my main objective is to take you through the presentation on clomiphene and letrozole, wherein we're just going to go through briefly on the mechanisms of action, but mainly we will concentrate on the various papers which have been published recently about different ways how we can use clomiphene and letrozole in our gynecological practice. Well, clomiphene, as you all know, it is existing in the market for last about 4 to 5 decades. We all have been using it, right from general practitioners to gynecologists. All over the world, clomiphene has been widely used. But you know something? Jokingly enough, we should say the difference of spelling between the European world and American world of clomiphene is also different. In American world, it is said F-E-N-E, while in Europe, it is pronounced as P-H-E-N-E. An interesting fact about letrozole also. The first thought that an aromatase inhibitor can be used for ovulation induction was floated by a biochemist called Mr. Bhagu Bhavnani, who was in Toronto, Canada. He told Professor Robert Kasper about aromatase inhibitor can be used in this different way rather than just being used in oncological practice. And then Robert Kasper put his paper forward for ethical permission for the use of aromatase inhibitors for ovulation induction. But then, in those days, the aromatase inhibitor was available only in injectable formats, and hence the permission was obviously not granted to do a vis-a-vis comparison with clomiphene, which was such a safe and well-established medicine in an oral ovulation-inducing agent. Later on, when letrozole was introduced in the international market as an aromatase inhibitor, and when Robert Kasper came to know about an oral aromatase inhibitor being available, an ethical permission was resought in comparative studies and its use in ovulation induction. I'm sure all of you gynecologists know very well about the mechanism of action of letrozole. Letrozole, being an aromatase inhibitor, does not allow the conversion of androstenedione to estradiol. Hence, the estrogen level from the ovary and the peripheral tissues falls down. The negative feedback on the pituitary is released, and in response to this low estrogen level specifically, there is a release of FSH, which in turn acts on the recruitable follicles and ovulation induction takes place. You are also aware about the mechanism of action of clomiphene citrate. Clomiphene, being an estrogen antagonist, it occupies the estrogen receptors both on the hypothalamus as well as the pituitary. Because of that, the negative feedback is released and hypothalamus in turn releases GnRH and pituitary in turn releases FSH and LH both. The FSH secretion from the pituitary increases, which in turn recruits the follicle, and the follicular growth and ovulation induction takes place. Let's focus on the difference of mechanism of action of clomiphene and letrozole. Clomiphene has a long half-life, and because of that it is retained in the circulation for a pretty long time. When clomiphene acts, the FSH is released. This FSH will cause ovulation induction and the follicles will start growing. The growing follicle will secrete estrogen. The estrogen then supposed to go back to the pituitary and tell, well, I'm arrived and now you stop your FSH secretion. That will close the FSH window. But that exactly does not take place with clomiphene around, because clomiphene, having a long half-life, it's still being an occupant of the receptor, does not allow the estrogen to tell the pituitary, well, it is there and the FSH window can close. So the FSH secretion therein continues. So clomiphene typically recruits more than one follicle. So multifollicular recruitment of eggs is very commonly seen with clomiphene. While in letrozole, it has a half-life of 24 hours. Once letrozole action starts, it will decrease estrogen, and then because of the negative feedback, the FSH release will take place. As the follicles is recruited and estrogen increases, this estrogen will go back to the pituitary. But by then, the letrozole action is over, and this estrogen, the feedback loop is still intact between the pituitary and ovary. And this estrogen will be able to tell the pituitary, well, it has arrived and it can stop the FSH secretion. Because of this particular action, the FSH window, unlike the clomiphene cycle, it closes, and monofollicular development is very commonly seen with letrozole. After this basic understanding of clomiphene and letrozole, let's start exploring its uses in our typical ovulation induction cases. All of you will agree that we induce ovulation for patients of polycystic ovary who are anovulatory, or sometimes we will cause ovarian stimulation or ovulation induction also for ovulatory women, especially when you are doing, let's say, donor IUI cycles or COH IUI cycles, you will be using that. So, which drug will you prefer for somebody who is ovulatory and seeking ovulation induction, and somebody anovulatory who is obviously seeking ovulation induction? As far as ovulation induction in polycystic ovary is concerned, A recent study, which was published by Richard Legro et al. From Reproductive Medicine Network, was a multicentric randomized study, and they compared head-to-head comparison between letrozole and clomiphene was done. Overall, across all body mass indices, they found letrozole scores better than clomiphene. The difference in pregnancy rate was almost about 8%. But as the body mass index increased, the letrozole was more effective than compared to clomiphene. So this simplifies a few things for us. It tells us when it comes to a high BMI polycystic ovary, letrozole undoubtedly will be your first drug of choice. In a normal body mass index, well, you can use clomiphene because the difference between the two groups was just 8% in the pregnancy rate, though they intended to have a difference of 10%. So clomiphene could be effective in that particular group as well. Were there any fallacies of this study? Well, this study was criticized for two reasons. One, there was no lifestyle intervention done amongst the patient. And as we understand very well, whenever a polycystic ovary patient comes, the first and foremost thing you do is lifestyle intervention. And I call it optimizing a polycystic ovary. When it comes to optimizing a polycystic ovary, one is weight reduction. Second, we can correct hyperandrogenemia a bit so that the ovulation induction is better. Both these two things were not done in this Rick Legro study. And we really do not know whether it can be replicated in other ethnic population, and the same differences in the action of letrozole and clomiphene will be found. So today, after the Richard Legro study, we all can say, or we can just have a consensus that when it comes to PCOS ovulation induction, letrozole will be my first drug of choice. But is it really the first line of therapy? We define clomiphene resistance very well, but is there something called letrozole resistance? Or let's say you can give increasing doses of letrozole, and if there is no ovulation induction at 7.5 milligram and above, then you say it is letrozole resistance. Then what is the treatment for letrozole resistance? Are you going to do laparoscopic ovarian drilling? Are you going to go to gonadotropin? Or can you restart clomiphene for somebody who is letrozole resistant? Is there something called letrozole failure? And will clomiphene be just out of practice when it comes to polycystic ovary? I think these are questions which are still unanswered. Now, let's come to another group of patients, which is the unexplained infertility. These are ovulatory women, obviously unexplained infertility, wherein you want to do ovulation induction for various purposes. Now, there is again the same network group, the Richard Legro group and P. Diamond et al. Published a beautiful article in New England Journal of Medicine recently, wherein they did a wide study with n number of 300 women who were randomized to receive gonadotropin alone, receiving letrozole and clomiphene, and getting the pregnancy rates. And they also assessed the number of twin pregnancies and singleton pregnancies in this group. And what this study concluded was gonadotropin had the highest pregnancy rate, the second was clomiphene, and the last was letrozole. Well, both the studies of Rick Legro, who are targeting the PCOS population, and that of the unexplained infertility, are telling two different stories. In PCOS, the first drug of choice would be letrozole, while in unexplained infertility, it's going to be the clomiphene when it comes to ovulation inducing agent with oral medications compared to letrozole. Now, why probably letrozole did not act well? Well, there is a secondary analysis of this study which has been recently published, which talked a lot about stress and effect of stress in ovulation induction. Also talked about the GnRH axis, sensitivity of the GnRH axis, which is altered, and because of that, probably letrozole is giving less pregnancy rates compared to clomiphene citrate. After these two decision makers, that is ovulatory women will go for clomiphene as a first drug. After knowing about clomiphene and letrozole, especially in polycystic ovary, the next drug which is commonly used by all of us is metformin. And last 2 decades, we have seen metformin being introduced in practice, then the role of metformin being questioned. So we are all confused. Should we be adding metformin to certain subgroup, or should we be adding metformin to all the people? Let me tell you how I understand this topic of usage of metformin in polycystic ovary syndrome. The egg, which is maybe 2 millimeter of preantral follicle, becomes a 20 millimeter follicle in just a period of 14 to 17 days. That's a huge growth for a cell. And that growth of cells, with so many granulosa cells being synthesized, is going to require a huge amount of energy. And that takes place just in a period of 17 days. And this energy is going to come from ATP of the Krebs cycle. For that, you require glucose. And glucose requires to be internalized into the cell, and you require insulin. So what I mean, the cell all the cells of the follicle need to be insulin sensitive so as to get the glucose, get the ATP running, and have more energy formed so as to synthesize more number of granular cells and in turn have a whole pre-ovulatory follicle being generated. So it is entirely an energy dependent process which depends on glucose and insulin. Imagine the same follicular apparatus being insulin resistant. Forget about the lady around the follicle who could be insulin resistant, may not be insulin resistant. If that follicular apparatus is insulin resistant, what will happen? Because of insulin insensitivity, the glucose will not be internalized, no energy, no ATP, the follicle cannot grow and it will be an atretic follicle persisting in that ovary. Well, this is nothing but anovulation. So, in a ovary, if there is insulin resistant, we'll have multiple anovulatory small follicles, but this is nothing but PCOS. So, if we understand the pathophysiology of PCOS in this fashion, I think there is no question about usage of metformin. We need to have metformin for every polycystic ovary. And whatever studies have been published earlier, they did say that metformin acts better in a normal BMI polycystic ovary compared to a obese polycystic ovary. So in a normal BMI polycystic ovary, we will be using metformin. For obese polycystic ovary, even if we may not have the ovulatory benefits, but metabolic benefits exist. The basic use of metformin there also is to reduce the carbohydrate urge when you are dieting or doing a lifestyle adjustment and reducing your weight. So I think metformin has its place in both the stories. Then there was a paper published earlier which said compared the use of clomiphene, metformin alone, and clomiphe and metformin together, which clearly said metformin was a poor as far as the ovulation induction was concerned. Rather, usage of clomiphene and metformin deteriorated the pregnancy outcomes compared to usage of clomiphene alone. So this was an Asian replication of similar trial wherein they did clomiphene citrate, metformin, and a combination group in a population of polycystic ovary syndrome. This was a very wide study which was published and which was had about more than 40 patients in each group of clomiphene, metformin, and combination group. And what they detected in the combination group, they had a pregnancy rate of 68%, which was the highest when clomiphene and metformin was combined together. And so, probably the usage of metformin, there could be a subgroup of PCOS where metformin works the best when it comes to ovulation. But still, we should use metformin for everybody. Either it will benefit the ovulation induction way, the endocrine parameters, or metformin will benefit us metabolically. And we do understand, though insulin resistance is not part and parcel of definition of polycystic ovary, insulin resistance definitely aggravates all the complications of polycystic ovary, especially the complication related to pregnancy outcomes like abortions, pregnancy-induced hypertension, IUGR, placental insufficiencies, gestational diabetes mellitus. Everything is high because of the insulin resistance there. So in some way, even if we improve the metabolic parameters, the live birth rate and probably the pregnancy outcomes could be improved with metformin. So I'm a strong proponent of using metformin when it comes to polycystic ovary ovulation induction. Well, folks, we understood the starting story of the letrozole, clomiphene, and metformin. Let's go a step further beyond this. We in our practice are commonly experiencing or getting patients of clomiphene resistance. That means you give 100 milligrams of clomiphene for 5 days, you wait for about day 14, day 15, sometimes even till day 20, 22, and you do not have any follicle getting recruited, and you call these patients to be having clomiphene resistance. What's a typical thing we all do? We typically will put the patient on some progesterone like methoxyprogesterone acetate or norethistron, get a withdrawal bleed, and then knowing that clomiphene has not been able effectively doing ovulation induction, we would go to FSH or HMG injections to cause ovulation induction. But this is called withdrawal bleed and FSH stimulation. But there's a paper which says that you need not wait for a withdrawal bleed. You can, if on day 15 you do not have any recruitment, that means no follicle is beyond 10 millimeter after clomiphene citrate 5 days of therapy, you can start FSH then and there, like a random start FSH, and take the FSH threshold higher than what clomiphene has already increased the FSH threshold and have an ovulation induction. That's very much allowed. What has happened is the pregnancy rate with this and after with the withdrawal bleed protocol also has remained the same. But time to pregnancy has drastically decreased, halved rather, if you do not go for a withdrawal bleed and go for a straight FSH stimulation therein. And this is also called a stair-step protocol. The stair-step protocol can be implemented in a little different manner, in I would say a very economic manner as well. For somebody who is not very comfortable using gonadotrophins, they could implement it in this particular way. Let that you are given clomiphene for 5 days. You call the patient on day 10 or day 11 for a scan, and on day 10 you suddenly realize, okay, well, it is clomiphene resistant, none of the follicle is crossing 10 millimeters. You restart clomiphene then and there. Again, you start clomiphene for 100 milligrams once a day for another 5 days. So, you are starting clomiphene again on day 10 for 5 days. What happens? Physiologically, the first clomiphene dose has taken the FSH threshold high, but that threshold is not able to recruit any follicles. So, you added clomiphene again and has risen the threshold little higher more. Clomiphene being a long half-life, the FSH doesn't come down below the threshold even if you stopped clomiphene few days back. And you can have another small rise in the FSH threshold. For all you know, a few of the follicles can get recruited and you can have an ovulation. For somebody who is economically constrained client, this can be used, and this is also called stair-step protocol using clomiphene. Not only this, we often get clients who could be wives of army people, or their husbands are away on job, or they could be in US, or they just come for holidays for 2 or 3 months and they are just desiring some kind of ovulation induction. Well, the lady just walks in and she says she's day 7 of her menses and she is polycystic ovary. And we all know that we generally do not start any stimulation beyond day 5, but not in polycystic ovary. You can do random start with clomiphene citrate even on day 7, day 10, provided the ovary is quiet. What I mean by quiet? Ovary is obviously studded with follicles, but none of the follicles is beyond 10 millimeters. The follicle is yet to be recruited and the endometrium is thin. In such a situation, even on day 7, day 10, you can start with clomiphene citrate, assume that as day 2 and call the patient for follicular sonography at a desired day 9 or day 10 when you require it. Many a times in this polycystic ovary patient, when they have prolonged period of amenorrhea, we have a commonly have an attitude, let's give progesterone for 5 days, get a withdrawal bleed and then start clomiphene citrate. Don't do that. If you are agreeing to random start, even if the lady comes to you after 1.5 months of amenorrhea, instead of giving a progesterone withdrawal, if again the criteria for clomiphene started are meeting, like you have a thin endometrium lesser than 6 millimeters and you have none of the follicles beyond 10 millimeter, you start clomiphene then and there. There is no need to wait for a progesterone withdrawal. And what literature tells us that if you go for a progesterone withdrawal and then give clomiphene, your pregnancy rates are rather lower than starting the clomiphene without giving progesterone withdrawal. Because by giving progesterone withdrawal, you are really depleting the estrogen very low level, and probably that does not allow a good endometrial proliferation, and that's why the pregnancy rates are lower compared to giving clomiphene at a random start. So do try it out with random start of clomiphene, and probably you will see benefits to your clients. How long can we give clomiphene citrate for ovulation inducing agent? I think that's a well-known fact that we will not be giving it for a real long time. Not only the risk of malignancy, but I would say we are giving a therapy which has a little lower pregnancy rates compared to gonadotrophins. And as a doctor, if you get a faster opportunity to use gonadotrophins in your patients, obviously you're targeting better pregnancy rates. And that's how I would say, though the literature says that giving 12 cycles of clomiphene citrate is associated with 54% of cumulative pregnancy rate, but that's all Western data. I really don't know how many Indian women would have some replication of data is possible in India, because our women do stand a little lower sensitivity to simpler ovulation inducing agents compared to gonadotrophins. So in India, I feel more commonly you can use gonadotrophin for ovulation induction. Probably you are doing better in achieving faster pregnancies. In the earlier slides, we did discuss about the insulin resistance and the common use of metformin. But now, what combination would be better? It is clomiphene plus metformin or letrozole plus metformin. There is a head-to-head trial which is available, which has been published from Tehran University, and wherein they said with clomiphene metformin, the pregnancy rate was 10%, but when they use letrozole and metformin combination, they could reach a pregnancy rate of 34%. So I think even letrozole and metformin combination is very much welcome in the group of polycystic ovary syndrome patients. What else is the determining factor for, or the most sensitive determining factor for ovulation induction with clomiphene and letrozole? It is the AMH. The geometric mean of AMH is 5.54 in ovulatory women, while the geometric mean is 7.54 of AMH in anovulatory women. So what we understand with this is higher the AMH, less would be the response to simpler agents like clomiphene or letrozole. Because AMH some decreases the aromatase activity, and because of that, it offers a resistance for FSH action. So what I understand the AMH story like this: if you plot a graph of the AMH level on the x-axis and the number of follicles on the y-axis, you will get a bell-shaped graph. There's a certain range of AMH which is low, wherein the follicular development doesn't occur very well, the number of follicles are less. Similarly, a certain high AMH does not respond well to ovulation induction because it offers a resistance to FSH stimulation. And it's the middle range which will offer you the best of the ovulatory rates and pregnancy rates of that of AMH. Let's look at what adjuvants commonly you can use that we know, understand that metformin, we are not talking it as an adjuvant, but it's one of our principal therapies in ovulation induction, especially in polycystic ovary. I think one adjuvant which comes to my mind is use of vitamin D. And most of the Indian women, or maybe because of the current lifestyle measures or whatever reasons, the vitamin D deficiency is very common, and it's our prime duty to replenish vitamin D. So, all in my practice, I start vitamin D2 by default to every lady and give it for 3 months, or may continue for a year also, so that the vitamin D levels are perfect, and then her chance of having an ovulation and a successful pregnancy will also be better. There is an article which is published in one of the journals which talks about the role of vitamin D in ovarian physiology, and especially in PCOS women, giving continuous supplementation of vitamin D decreases the abnormally elevated AMH level. And well, if that is true, then it definitely will make a difference in ovulation induction in polycystic ovary. So by default, giving vitamin D is worth a thing. Now let's focus on some recent papers which have been published on newer way of using clomiphene and letrozole in our practice. Let's go to the first paper, which was published in Reproductive Biomedicine Online in 2007. This was a Japanese paper wherein they designed a protocol wherein 50 milligrams of clomiphene was given from day 2 of the cycle throughout, and after 5 days, the gonadotrophin was started to her. In spite of starting of gonadotrophin, the clomiphene was not stopped at all. When the follicles reached 18 millimeter, a trigger with GnRH agonist was given and a oocyte pickup was done further. And wherein they need not use antagonist in this particular group. Clomiphene, as we have understood earlier, that it has a long half-life. It will occupy the pituitary and hypothalamic estrogen receptor for a long time. So whatever ovulation induction takes place in this particular protocol with clomiphene earlier and gonadotropin later, and the estrogen rise takes place, that estrogen rise cannot have a positive LH surge because the receptor there is still occupied by clomiphene, and hence there is no fear about premature luteinization and no need to use an antagonist. So your cost comes down, and well, this works very well in poor responders. There is Dr. Mohan Kamath from CMC Vellore published a similar study in oocyte donors, wherein he used 100 milligrams of clomiphene continuously for about 12 days, and all those 12 days the lady was taking ovulation induction, ovarian stimulation with gonadotrophins, and did nullified the need of using GnRH antagonist, which is extremely good, especially for a donor, because oocyte donor is serving like a god. She is taking injections for somebody else, and if we can decrease her set of injections, it can not only decrease the cost, but a physical trouble to that lady will also be decreased. Another novel use of clomiphene in IVF would be clomiphene co-treatment in routine antagonist cycle, wherein you are giving 100 milligrams of clomiphene from day 2 of the cycle to day 6. Obviously, you are starting your gonadotrophins also on day 2, and day 6 onwards, you are adding an antagonist. This was a co-treatment group, and the control group would be a normal antagonist cycle wherein there is a gonadotrophin and antagonist added from day 6 onwards. What they found that in fresh embryo transfers, the LH levels were better in the luteal phase because the long half-life of clomiphene gave a better LH level in the luteal phase, but this was only in fresh transfers. Now is the era of freeze all policies, of vitrification all cycles. So whether that clomiphene can cause antagonist endometrial side effects is none of a concern as we stand today, because we are giving clomiphene, causing ovulation induction or ovarian stimulation, retrieving the eggs after ovarian stimulation, then freezing the embryos, and then taking a gap of 1 to 1.5 months and then putting the embryos back. So the clomiphene deteriorating the endometrial, that factor wouldn't exist or wouldn't trouble us in our practice. But what about IUI cycles? What about clomiphene uses in routine ovulation induction where we are not doing ART or not we are doing IVF? How do we know about endometrial toxicities developed or no? All the previous papers talked about when you give clomiphene on the day of HCG, if your endometrium is less than 6 millimeters, you will say, well, this is a thin endometrium because of clomiphene. And if there is a thin endometrium, this clomiphene should not be used again. There is no point correcting thin endometrium by giving any estradiol supports as well. But there was a recent paper published about the endometrial thickness and IUI outcomes, and it said aptly how thin is too thin. And it clearly said that in spite of thin endometrium, do not cancel IUI cycles. You can go ahead with it. And it's logically very correct. Let's assume a patient who has 5.5 millimeter of endometrium on the day of HCG in an IUI cycle. You're going to give a trigger with HCG. The follicle is going to rupture by about 36 hours. Then you will do an IUI. Then fertilization will take place. After fertilization, by the time it becomes a morula and a blastocyst, another 4 to 5 days for the blast to come to endometrial cavity. So it's about 7 days after the injection of HCG, the blastocyst is arriving at the endometrial cavity to get implanted. And all these 7 days, because of your trigger, your progesterone and estrogen both are rising from corpus luteum, which in turn is improving the endometrium. But are we scanning our patients on day 7 of HCG? No. We will straight call them on whether they get menses or they don't. If you start scanning these patients, you will realize that most of them have auto-corrected their endometrium and that endometrium has crossed 7 millimeters. A very few of them would not have auto-corrected and that endometrium would be 5 millimeter or less. That probably is a true endometrial pathology which needs to be evaluated. We cannot blame it on clomiphene, then it is because of clomiphene, and we do not attend to the truth. And could be some intrauterine adhesion or could be some chronic endometritis, and that could be leading to endometrial thinness. Agreed. A long term and clomiphene therapy for maybe 6 months or a year can deplete the estrogen receptors in the endometrium. So chronic therapy can make a thin endometrium case, but that's a different issue altogether. I'm talking to a particular case in such. Secondly, uh, in IUI cycles, it wouldn't make a difference. But when it comes to thin endometrium in IVF, it will make a difference. Because Robert Casper put forth this theory that whenever there is a thin endometrium and you put an embryo, the embryo is more in an aerobic atmosphere. An embryo typically requires a hypoxic atmosphere. That's why we use carbon dioxide incubators in our laboratories and hypoxic atmosphere to grow. Since the embryo is growing in a thin endometrium, the embryo is near the radial vessels, so oxygen concentration is high, and probably that's the reason thin endometrium in IVF makes a difference. But probably when it comes to IUI cycle, it would not be making a great difference. Then, how do we know that clomiphene has caused problems in the endometrium? I think simply you just ask the lady whoever has taken clomiphene, did you bleed less after your clomiphene citrate therapy? And a typical Indian lady will be very well aware about the scanty menses compared to the normal menses she gets because she gets scared or gets very anxious about the scanty menses. So if you get that history, that means probably your endometrium is affected by clomiphene, and that simply will be available in most of the Indian women. As we came to know about a clomiphene co-treatment in IVF, can letrozole be used as a co-treatment in IVF? Yes, even letrozole can be used. Letrozole co-treatment in IVF would, number one, increase the androgen levels in the ovary. Intra-ovarian androgens will go up, so more substrate will be available for conversion to estradiol. Secondly, the estrogen receptors in the endometrium will be downregulated and there will be better proliferation of the endometrium, and hence they have reported low miscarriage rate and better pregnancy rate after using letrozole as a co-treatment in IVF cycles. Let's explore some different uses of letrozole which have been published in the literature. And this is one paper which has been published from the University of Hong Kong, which talks about using letrozole for medical termination of pregnancy. Agreed, MTP is regulated in India, so we wouldn't be using something off-label, but you can use it in missed abortions. So instead of using mifeprin, if you can use letrozole 10 milligram a day for day 1 and day 2, and day 3 you give misoprostol 400 microgram, and you can have a medical termination of a miscarriage. It is possible. So letrozole can be used as a surrogate for mifeprin in such situations. I commonly use letrozole for another indication. Again, I would say this is a little off-label use, very few studies, just sporadic one or two mention of this particular use is there. We typically, at around 35 years of age or 35 to 40 years of age of a lady, she suffers from adenomyosis. And we get these patients with severe cramps in abdomen, with menorrhagias, and they are seeking some kind of medical treatment. We know that probably something like a levonorgestrel intrauterine device would be a very good therapy. but there is a little low acceptance rate to start with. She mentally needs to prepare to accept levonorgestrel intrauterine device. And she's not willing to go for a surgery also. And at 35, we wouldn't like to knock off her uterus for simple adenomyosis. If we can treat it medically, we'll be better off. In such patients, I make a combination of using medroxyprogesterone with letrozole. So from day 2 or day 3 of the cycle, I will be putting the patient on medroxyprogesterone acetate 10 milligram a day, or even norethistron 10 milligram a day. I give 5 milligram in the morning, 5 milligram in the evening, and with letrozole 2.5 milligrams continuously for about 25 days. What it does, the ectopic endometrial deposits in the myometrium will be decidualized by the progesterone we are using, and the very core of it, that it needs estrogen to proliferate, that estrogen we are not making it available because we are continuously giving letrozole. So letrozole drops down the estrogen, and whatever endometrium gets decidualized, so her symptoms become free and she is very well relieved. I typically use this for patients who have adenomyosis where the uterine size is less than 10 centimeters. If it is more than 10 centimeters, sometimes this treatment can fail. Very first cycle, you may not have the best of the results. You use it continuously for about 4 to 6 months, and it has very good results. I commonly use this as a stopgap treatment before I go ahead with a levonorgestrel insertion or going for taking the client up for surgery for my patients. Well, I think in summary, I've just told you about the mechanism of actions of those drugs. Then we explored how we will approach our unexplained infertility, PCOS, how we will give metformin, the use of metformin. Then we talked about how we can combine these drugs with gonadotrophin therapies. And with so much of evidence being clomiphene being one of the main drug of treatment, especially for poor responder in IVF, a combination of clomiphene and gonadotropin giving a better result with embryo pooling concepts, everything coming up fastly in our practice. And we in India see so many women with poor ovarian responses, wherein a drug like clomiphene still has its great role to play. I'm sure these drugs are not going to die away. We are going to explore more uses of clomiphene and letrozole in future. Please do send your feedback. Thank you so much.